Professor Rela could not make it because he's not keeping too well. So we move on to the next session. And to moderate the session, we have Dr. Malti Satyashekaran. And our panelists will be Dr. Venugopal, Professor B.S. Ramakrishna, Dr. Naresh, and Dr. Nirmala. Dr. Nirmala, Dr. B.S. Ramakrishna, Dr. Venugopal, and Dr. Naresh as panelists. And to chair the session, we have Dr. Sumati, Dr. V.S. Shankar Narayanan, and Dr. R. Velmurugan. I do not know why pediatric session is always at the end, the last session. So next time, next time we'll keep it as number 1 session. Over to Dr. Malti.
I consider it a great privilege for this, wish to thank the organizing committee for giving us this time to talk to you and share about a little different aspect of what you've been listening since morning. We are going to talk about the malignant liver tumors in the pediatric setting. Especially I would like to thank Dr. Joy for giving us this opportunity. In this panel, actually we should have had Professor Rela, Dr. Neelam. They could not make it, but we have replaced them with Professor Ramakrishna. We've got, anyway, we have our original panelists are still there and they will make it up for us. You've heard Dr. Venugopal this morning. He's a senior liver transplant surgeon from BGS Global Bangalore, and we all know Dr. Naresh. He's the lead liver hepatologist from Dr. Rela's Institute and has been working with Professor Rela for several years, and both of them have published several articles on this topic. So I would like to also thank Professor Rela's team who have shared both the cases, and it is from them. So I would like to thank Professor Rela, Dr. Naresh, Dr. Jagdish, Dr. Mukul, and Dr. Joy for giving us the pictures, the histopathology slides. And we've been listening since morning regarding the various aspects of HCC in adults. We have seen what has happened over times regarding the etiology, the biology, the problems when it's with cirrhosis. And sometimes we feel we have conquered HCC in adults, but we know it's not true, that there is a future for HCC in adults. In the same way, we have also come a long way in the management of children with liver malignancies. We know more about the etiology now, we know something about the biology, we know something about the treatment, and definitely I think Dr. Naresh and Dr. Venugopal will agree that our survival rates have improved over time. Survival rates have improved, and sometimes it's much, much better than the survival rates which are seen in the adults with HCC. It's not because the expertise is different or that we have learned more. We have understood the biology, and then we realized that adult HCC is different from pediatric HCC. I think that's what is very, very important. And so here we have as chair, no one young, Dr. V.S. Shankar Narayanan is there, Dr. Sumati is there, and Ravi did not want to go to that side. He said, no, I will sit here, but we will ask him questions. Otherwise, he will not get his tea. So here it's a 1 year, 10 months old male child born in Oman. He was born full term, cesarean section, perinatal, antenatal period was uneventful. Birth weight was 3.1 kilo. And his mother, I think the mothers are the best to notice that the child has upper abdominal distension. Usually when they give a bath to the child, they notice that there's something more than what they saw. And there was no fever, no jaundice, no GI bleed, no seizures, no breathlessness. And as usual, they must have taken it to the doctor, and they did an ultrasound, and they found, to their surprise, a large SOL in the right lobe of the liver. So this time it was 1 year and 4 months. And you see this pedigree chart, and that's the baby at the last. I don't know why Dr. Naresh had written, born to one wife. You wrote that? Because, and I was surprised, I thought, am I reading it properly? But here, so it's non-consanguineous, born, so they've come from Oman. So it's very, very important. And he said, born to the first wife. And no consanguinity, no family history of liver disease, no developmental delay, no bleeding PR. That means he was thinking about familial adenomatous polyposis, no SIB deaths and abortion. So all this history is what we got from the chart because the child is from Oman. So the relevant data which we got from that file was only that the child was looking good. Liver was there, 3.5 centimeters below right costal margin, vertical span 9, spleen not palpable, no free fluid, hemoglobin 9 grams, but LFT was generally, overall it is a normal LFT, but the alpha fetoprotein much higher than what you've been listening to in the morning, 400s. Here we have a reading of 17,505 nanogram per ml. And so what next, Dr. Naresh? You've got this, you've got an ultrasound, you've got a high alpha fetoprotein. What do you think they should have done after this?
Yes, alpha fetoprotein is quite high, as Madam said, but this is, I think we have to understand, it's fetal protein. Newborns can be born with more than 1 million AFP, so we need to check the nomogram to see where it stands. Sometimes it takes 2 years for the AFP to normalize in children, but anyhow, this 17,000 is quite high for a 1 year, 4 months. I think next would be, I think we need to have a radiological imaging to, already we know there is a mass. So we do a contrast CT of the liver and also the chest. Essentially, we don't need a PET scan. We just need a lung and abdominal CT because this tumor doesn't metastasize anywhere. So we think hepatoblastoma is the most important cause for this.
Plump diagnosis. What? That's the training in India, no? So Oman, they thought of the same thing, and this is probably the arterial phase, and you can see a huge mass. It's probably a heterogeneous enhancement, and you can see a peripheral enhancement also, and this is probably during the venous phase. You are seeing a different heterogeneity, and here you are seeing it in a different plane. It's quite huge. What do you think the segments would be? Anyone would like to take that? Just when you would have seen so many CTs like this, it seems to be occupying the whole liver. But sometimes you cannot, because sometimes the tumors bulge into the other segments, but probably it will be 7, it will be 8, and maybe 4A, 4B. Do you think that, the whole thing? But you cannot just say that. But something more interesting, when they did a CT chest, they found something more. Dr. Ramakrishna, would you like to comment on the previous pictures? And
see the arrow pointing to something in the heart. I guess it's not clear.
Not very clear, but they also felt whether there was a tumor embolus going through the IBC, going into the right atrium, and they saw something there. So for them, it must have been something a big challenge. But they had to start the treatment, and you see here also they are able to show something in the right atrium. And so they made a comment on that, but they said they would start the treatment because they said it would be that, but to confirm. So here we have a large lesion. They've said it is probably those segments, and they said maybe there's a vascular invasion of the right hepatic vein, the IVC, the right atrium, the right pulmonary artery, pulmonary nodules seen. What would you do like this when you get a case like this, Dr. Venugopal? Would you say, please stay back in Oman, or would you say, please come over? Or they've sent an email to you.
Come back to India.
Come back to India. Come to India. So come to India, let me see. Let me see what is that. Is it there? Is it not there? Let us see what is happening. So yes, they did come, but let us see before that. So Neelam is not there. So Nirmala, this is a large SOL in a 1 year, 4-month-old infant without liver dysfunction, but with a high AFP. So what are the possibilities? See, the teacher likes you, so they will give the answer also. So you can say, yeah, what are the possibilities for you, Nirmala?
We are looking at hepatoblastoma with high alpha fetoprotein. Then you can have teratomas, which can present with high alpha fetoprotein. But then there are other hepatocellular carcinoma lower down the line because a well child, not metabolic, and high AFP is not that characteristic.
So this High AFP may not be there in 3 and 4, but the first two, see the order is changing in children. It is not HCC first, but it becomes hepatoblastoma. So hepatoblastoma becomes first and HCC becomes the second. So this is the actual differences between hepatoblastoma, hepatocellular carcinoma, and the latter two. The third and the fourth columns would be the benign tumors, and the black columns would be the malignant tumors. And here Dr. Naresh and all the others feel it would be a hepatoblastoma, and it's the most common tumor in children, and usually associated with some syndromes like Beckwith-Wiedemann and FAP, and very low birth weight babies. And this is what I am now scared about, because the neonatologists are giving us more babies like this, young babies, and they're so proud about that. 1 kilo baby I have saved, 1.2 I have saved. Definitely the incidence of hepatoblastoma is going to increase now. Preterm babies, VLBW, so that is going to increase. And what is your comment on that?
I think we do see with twin pregnancy, particularly IVF babies, though we have published around 30 children, that was 3 years ago, now we have around 60 children. At least 4 of them were twins, one of the twins getting that thing. But in literature, we don't see a statistical significance, but I think it's to do with the numbers. When the numbers go up, we might find that it's one of the...
I think the birth weight, they have given a lot of importance. Any baby less than 1.5 kilos seems to have a higher risk rate compared to a baby who's more than 1.5 pound. And so they can present with abdominal distension. We were talking about the CT abdomen. HCC is usually occurring in a little older child, though we have seen younger, but usually around more than 5 years. And the predisposing condition, we'll be talking about that in the next case. Metabolic liver diseases, we also have hepatitis B, and C we don't see because it takes a longer time, and these are the two conditions where we have alpha fetoprotein elevated. Of the benign tumors, the infantile hepatic hemangioendothelioma, earlier it was called hemangioma, which was earlier called as hemangioendothelioma. There the AFP is normal. That is also the most important lesion. So here today I think our point of discussion would be the hepatoblastoma. So this is the most common primary malignant liver tumor in children, and of the pediatric liver tumors it is about 40%. Incidence is 0.5 to 2 cases, and the onset is usually around 16 months. The cause is unknown, but we have chromosomal abnormalities. We have these, as I was telling you, very low birth weight infants, and there's a high association. Something very interesting is what we have been talking about here. It's a little different. Hepatoblastoma is not usually associated with cirrhosis or metabolic liver disease. So I think that is very, very important. So if you can do a resection wherever it is, you can resect it. Unlike, you have this problem of HCC, so you don't do it, but that's one important thing. So this is a histological classification. It's not very important, but remembering it's an embryonal tumor. Like he was saying, you could have the mixed teratoid tumor, you could have calcification, and you could have. So I think, Dr. VSS, you also agreed up to this that this will be a hepatoblastoma, or you think something different?
Can this not be diagnosed antenatally with ultrasound? Is there a tumor or not? How is that missed?
Antenatal.
Antenatally?
Yeah, they don't have...
Fetal ultrasound should have brought out this tumor.
No, we have seen...
Why should they wait?
No, we have seen hepatoblastoma from day 2 of life, but the child had an antenatal scan at 32 weeks. At that 32 weeks, the tumor was not picked up. So I don't know, something has been happening in between.
It's not always intrauterine, sir, because the peak thing itself is 16 months. So after that only, it is a problem starting intrauterine, maybe a tumor embryonal, but I think the presentation is not there. There are not reports of antenatal. What about Ramakrishna? Do you think this is picked up earlier?
Yes. After all, 1 month?
Intrauterine.
I guess it depends on when the
Depend on
scan
what
was
is
done.
the presentation and when it comes, I think. Because like you said, the tumors also are there. So now, what would you do now? You've got a CT picture. Would you just do a biopsy and decide? Would you biopsy and refer to the surgeon? Would you do a true cut biopsy stage and give a neoadjuvant chemo? Would you refer to surgeon for upfront surgery?
Essentially, we need to have it's a multidisciplinary approach. So we know that this is a tumor, most probably hepatoblastoma. And there are some recommendations saying that if the age group is between 1 and 3 years, you don't need a biopsy to start the chemotherapy. But standard, I think for a medical legal purpose, we do a biopsy. And once it's confirmed, there are two ways of treating it. One is resection followed by chemotherapy.
So you want to do the second biopsy, staging neoadjuvant, that's your choice. Or any others? You have a surgeon who's your very good friend. You would like to refer straight for the upfront surgery. Dr. Venugopal, would you like them to send straight to you?
The classification comes in the pretext 3 or 4.
You would also like
vascular invasion extension to right atrium. So it's a high risk category. So straight away go for.
No, but you know, they were all talking this morning. They don't biopsy at all. They don't want biopsy. Do you want a biopsy? Banu's there. Do you want a biopsy?
Conventionally, yes. Definitely.
Yes. So I think in children, I think we tend to biopsy more. We want that. We want that histology. We want that grading. We want it. Even a liver biopsy, we tend to do more than what you all do for in adult hepatology. So yes, that was the answer. True cut biopsy, staging, and neoadjuvant chemo.
If I go as an examiner, I expect my postgraduate to say that make a difference between a biopsy and image-guided biopsy. These are the people where we have a localized tumor. Rest of the liver appears normal. I expect my PG to say image-guided biopsy rather than a simple biopsy. So,
Image-guided biopsy is extra marks for you, Naresh, if you go for the exam. That's all. He will use it.
Targeted.
Of course,
So
of course.
Because it's an invasive procedure.
Yes, yes.
Parents have to accept it.
That's for
So
extra
image-guided
marks.
biopsy should be the answer.
So, Dr. Venugopal, you were talking about pretext staging. Is it important? And I think Naresh can just tell us about this. Do you think it is important?
Unlike other classification, here what we do is pretext classification. This is pre-chemotherapy classification. What we are intending here is this tumor is quite sensitive to chemotherapy. So it can shrink dramatically, so the surgery can be done much easier. So there are, it's been divided into 4 based on the liver segment. Essentially stage 1 where 3 contagious sectors are free, 2 is 2 contagious sectors are free, and 3 is 1 sector is free. So until stage 3, these are all resectable tumors. Or stage 3 when it's central, then they might need to go for transplant, or stage 4 when it comes, then it's for a transplant. And then we add the VPC based on vascular invasion, extrahepatic distant metastasis, which most likely a pulmonary metastasis. So it's quite essential for a pretext staging because once we start the chemotherapy, after 4 cycles we will redo the CT scan to find out where exactly the patient stands.
So this, Dr. Venugopal, is the same staging you also do, or you all have any other staging? Because the number of criteria they have for adults, I think
this is a standard staging system followed across the world now. But we do have other staging systems like COG staging system and TNM staging system.
But this is
a standard system.
I think this seems to be very simple, and you all should remember that the caudate lobe is not included in the sectors. Caudate lobe is separate, and when caudate lobe is involved, you put it as an additional involvement. I think this morning also people were saying that when the caudate lobe is involved, the surgery itself becomes very difficult because the vessels are there and then you get a different thing. So in the sectors, the caudate lobe is not been involved. So yes, the biopsy was done and they showed, this was all done in Oman, a diagnosis of hepatoblastoma was done. Dr. Venugopal, now you've got a staging, you've got the biopsy, and probably the staging would probably be pretext 3, the way it went. Maybe max would have had 1 sector free. How do you like to classify now the risk in this hepatoblastoma, and what is the significance?
Pretext 1, 2, 3 are classified as standard risk patients, and pretext 4 with vascular invasion, extrahepatic disease like pulmonary metastasis are categorized as high risk patients.
And what is this? Why this, when the alpha fetoprotein is less than 100, they say it is high risk? How do you, what do you want to tell? Because there are a lot of PGs here. So sometimes you think when an alpha fetoprotein is low, maybe it's good. But here we take alpha fetoprotein less than 100 being a high risk patient.
Yeah.
Can have a mixed element like HCC added on element into it. So AFP less than 100 is actually what we have seen is they have quite bad prognosis. So if the AFP is low, we would rather straight away, if it's a resectable tumor, rather than neoadjuvant chemotherapy, we would go and resect the tumor.
So I think that's very important. And a child, if you diagnose hepatoblastoma when it's more than 8 years also, it's not a good sign. So, Dr. Venugopal, you've agreed that we do the pretext, we've classified, and which guideline protocol do you prefer in the management of hepatoblastoma and why? Here the same way, just like you all have, we also have several protocols, but most of us follow some protocol. There are management protocols which you would like to say?
Generally, we follow the COPL protocol.
COPL,
where
okay.
most of the patients undergo neoadjuvant chemotherapy.
You do the
and
pretext staging, and you always like to downstage the SOL, and then you do the resection. So I think that rather than the COG, where they do upfront surgery followed by adjuvant chemo, but I think the recent papers, they are also now trying to do the downstaging.
Even
And
COG is only applicable for pretext stage 1 and stage
Yeah.
2. Even stage 3, they do neoadjuvant and then go for a resection.
so I think most of us follow the COPL, where you do the pretext staging, then you try to downstage it either with chemo, the plado and the super plado, which they'll be telling you about, and then we give the resection followed by the chemo. So what is this plado and super plado? I think we've heard a lot of abbreviations since morning, and then we go back, we are all confused about all this. What is plado? What is super? What is this?
Plado is cisplatin and
The platinum of cisplatin, the plado, and the DO is probably just the...
doxorubicin.
Yeah, so I think this is all. It is plado, is cisplatin and doxorubicin and super plado. You can just tell them when you use this and...
Usually for a standard risk, we go for plado, and high risk, we go for super plado. And essentially, this chemotherapy regimen is not that toxic, and even peripherally we can be given, and children tolerate them very well.
So all of you should remember that after the staging, they all go through this chemo, very standard. And if it's high risk, you use a little different platinum, carboplatin you alternate with doxorubicin, and some of them give it every 2 weeks for the high risk. So the high risk you already know, pretext 4, and whenever there is an invasion of the vessels. So on risk stratification, this child seems to be in the high risk. So how many cycles of chemo do you prefer, Dr. Venugopal? And do you wait for a preferable percentage of reduction in tumor size? And what is post-text evaluation?
Usually we give 4 cycles of chemotherapy.
Four?
And at the end of 4 months, reassess with the imaging and see how much has regressed and whether it has become resectable or not. If resectable, go with the resection. Otherwise, give further chemotherapy.
Any other opinion? I don't know, Dr. Ramakrishna, we are not okay.
Yeah, so first 4 cycles we give, assess if it's borderline resectable, can go for another 2 cycles and take a call on it, but maximum 6 cycles. After that, tumor resistance develops and the AFP starts going up, and that's really difficult to manage.
So I think that is a very important and practical question. 4 cycles definite, reassess, and then if it does not, try another 2, but not more than that, and then you can either take it for resection or you do a transplant. Only 2 options. Here we don't go for taste, stare, so it's much easier for us. All that different things, all that is not there for us, no? Not here. So no taste, no tear, nothing. No. So straight either 2. We do resection or we do transplant. So child was given 7 cycles of chemo, little more than what, because I think they had to get their ticket, they have to come over here, they have to get their money. I think that 1 more cycle
because,
maybe.
Yeah, the decision, when we take the decision of transplant at 6th cycle, it takes at least another 1 month to make them ready.
Yeah.
So we don't just leave them, we make sure we give 1 more cycle in between before taking up
This
for
is
transplant.
a 3-weekly cycle, so you can imagine 7, 21 weeks, so this has happened. And so in AFP in 2019 was also 4,981. You expect this value will be there?
Yeah, that's a fantastic thing. What we want to see
17.
is a serial decline.
Oh.
I think the numbers can be different, but this number we would be very happy.
Very happy. So there was a decline from 17,000, but they realized that there was more to be done, and so they came here. And so they took their flight and they came to Raila's Institute. And here, this is a new one which Dr. Raila's Institute, it looks like a palace over here. So they also were happy when they came from Oman. And here, this is the data which we have here. Case in Chennai, the child is stable. See, all the parameters except the hemoglobin is also improved. The INR is good. That means hepatoblastoma, the liver function test is more or less stable. It doesn't become worse. Look at the huge tumor, such a big tumor for that child, for a 1 year, 10-month-old child. But somehow the liver function, because the rest of the liver is normal in this child. And so it's functioning very well. The alpha-fetoprotein in our center was, in their center probably was high. So what next, Dr. I think Nirmala, you can answer for Elam. What would you like to do now? Would you like to assess the tumor or?
Yes, I would like to repeat the
CT?
imaging and the other tests. Already they've done, I would like to repeat the image.
So the CT seems to be remarkable. There seems to be a very good decrease in the size of the tumor. You can see the tumor now, it's becoming much smaller. In the arterial phase, it is showing a heterogeneous enhancement. There is some peripheral enhancement. And then, yes, it is there. The vessels are splayed, but the rest of the liver looks okay. So maybe it was just bulging into some of the sectors and now it looks better. It's this phase. So now I think, Dr. Venugopal, you have the one who only surgeon over there. So you got caught between 3 physicians there. So what are the surgical challenges you anticipate in this child? Here's a child who's finished 7 cycles. It's pretext 4. It's a high risk. They saw something in the heart, and then they said the right hepatic vein, the IVC.
Tumor was infiltrating the IVC and right hepatic vein and extending through the right hepatic vein
and
into the
we
right
showed you one
atrium.
pulmonary metastasis also, one lung metastasis also.
So the challenge here is we have to resect the IVC and right hepatic vein. And then if there is tumor thrombus extending, remaining tumor thrombus into the right atrium, that also has to be removed. And this patient, the tumor was extending to all the 4 sectors of the right lobe plus segment 4. So he will need an extended right hepatectomy, caval resection, and plus or minus the thrombectomy.
So with
from the
this
right
type of a picture, would you say I will just take the child for a transplant? Why do such a major surgery for this child? Why don't you say, okay, this child has this, that's that, why let us go for a transplant? What would you like to try? What do you think was the response in this which made you say, let us try surgery?
If it's a resectable tumor, I think transplant is not the solution for everything. I think we are replacing one disease with other disease. So if it's a resectable tumor, post-transplant with immunosuppression, things can go all the way around.
So the lead hepatologist, liver transplant person itself is saying, when you do a transplant, you bring them from one disease to another disease. So remember that. Very, very important to remember that. Everything is not transplant. And so if you have a nice liver, the rest of the liver looks good, there is a response, it has regressed. And if you have a good surgeon with good expertise who are able to do it, Dr. Venugopal has said it so well, he will do it. He can do it. So give it to them, let them try that. And so
Decreasing alpha-fetoprotein is a very good sign for that the tumor is regressing. And this child will do fantastic if we do a resection, if possible. If not possible, that's a different scenario. I think now with the tumor regression, you can see it's well sort of marginalized and they can do the resection now.
So when would you prefer a liver transplant directly without going through this?
If it's as a pretext 4,
Pretext 4.
or even pretext 3 with central pretext 3. These are the 2 indications where we go for a transplant.
So the transplant for hepatoblastoma is only pretext 4 or pretext 3 with a central tumor, and where you find that, you know, they have not improved with your chemo. I think that's very important. So as Dr. Venugopal was saying, extended right hepatectomy with caudate excision was done. Tumor thrombectomy in the cava at the hepatic venous orifice level, and the retrohepatic cava excision was also done. You agree with that? This is what was done. And this is the nodular viable tumor which was removed. It's a beautiful thing where you see the sheets of these cells, and here you have this fetal epithelial cells arranged in the trabecular pattern. So just like you have, it's a teamwork. That's what I think you all should remember, that everyone has joined in to work, and then here you have a child who's done so well. And this is one of the IHC staining, glypican 3 in hepatoblastoma. So the child tolerated the procedure very well, discharged, advised to come for follow-up. I think December 13th was the surgery, so I think this is just 1 month. So they are waiting, but they've heard that the child is doing very well. You would like to?
Usually following this thing, they get another 2 cycles of chemotherapy, and then with that we will stop the chemotherapy. So this child is waiting for further chemotherapy.
So have you seen recurrence, sir, of hepatoblastoma, Dr. Venugopal? No recurrence, you've not seen. Have you all seen recurrence?
Recurrence we have seen. One thing is, if the AFP goes down, if the AFP doesn't respond to your chemotherapy, that's a bad prognostic sign, and these children sort of never made up even to a transplant. I think in our experience, 5 children who didn't respond to chemo, they died straight away. Those who respond to chemo, 95% of them are doing well. I think after 2 years, we had a couple of children with metastasis we found out in lungs, which was resected, and these children are doing well, actually.
So there is a small part. I think how to prevent in preterm, I think it's going to be a very difficult answer, because on one side we are having more preterm, but I think they have to be followed up. There's been a large series of studies where they have followed it up. We don't have an idea, but they said giving more oxygen for some of these babies was one reason. Some have said some of the medications which were given could possibly. So it may be a multifactorial reason, and especially parents who went through fertility treatment and had the babies, they seem to have more of hepatoblastoma. The precious children, from the beginning precious, and they also get this. So I think this is probably the future in our management, how we improve the survival. So you want to say something, sir?
Only one word. As an observer, it was delightful discussion. There are 2 people in the team. I need clarification. The role of pediatric surgeon, primarily, is he going to keep quiet or is he involved? Second, chemotherapy. Who gives the chemotherapy? Hepatologist?
Here it was
Or
a pediatric oncologist.
chemotherapist. Do we involve those people also
Yeah.
in the team? That's what I want the postgraduate to be a little more clearer. The team consists of whom?
Yeah, that's what
3, 4, 5.
is the one.
The person who
Multidisciplinary
referred to
team.
you is the neonatologist.
So the multidisciplinary team
Ultimately,
is
he is the fellow who is probably worried.
I think
What happened?
hepatologists can do, because
Just tell
personally
us.
I have been doing chemotherapy until I had an
We can have.
oncologist. So
But
What do you advise generally? No, everybody cannot come to you.
So it depends on where.
No, once
center.
it's,
The
Depends
question
on the
is,
center.
this,
So,
we
sir,
have
we
decided
continue.
about
We
the
have one more
candidate
thing.
diagnosis, right?
So before Jayanti rings the bell, this is the messages, and like Dr. Thing, and in this paper also insisted on the multidisciplinary team approach. You need a team. It may be difficult at times because they may have some side effects for the oncology medicine. So they are there. The pediatric surgeon is also there, but then when we have expertise, we hand it over to
completely
the
managed by pediatric surgeons.
So these are the messages which we have given, and so we'll go to the next case, and that is the most important one, which you will not see, metabolic liver diseases and HCC. And so HCC in children, as I told you, this is the second common malignant liver tumor. The incidence is definitely less than seen in adults. It's 0.3 to 0.45 cases. As I told you, children in HCC, it's usually more common, more than 8 years, peak 10 to 14. So do you think that pediatric HCC is different from adult HCC? If so, in what are the salient differences? I think you should be also aware about that the HCC which we see is different from what you all see. Naresh and Dr. Venugopal, otherwise I'll just read because the background itself is different. In adult HCC, you were talking about the chronic necroinflammation going on, either due to alcohol, either due to viral HBV, or due to NASH. But here we may get it in a non-cirrhotic liver, in a normal liver, and it's more due to a toxic metabolite or a mutated virus. We do not have much of gender predilection. And more or less, the incidence has been stable over 4 years in HCC, whereas the HCC seems to be increasing in adults. The fibrolamellar variant of HCC, it's much higher in children compared to adults. Response, I think that Dr. Naresh was not too happy about the response, though there's a paper that the response to chemo is little better in children compared to adults, but liver transplant offers a better cure and the survival rates are better. And then there are a lot of differences in the pathways, the genetic pathways and the mutations between the two. So this is one paper which I think you all published, where you said that the pediatric hepatocellular carcinoma in a developing countries, the etiology changing, and they came to a very good conclusion that in children, younger children, it's more a background of a congenital or a metabolic liver disease, which is the cause for the HCC, and many of them can be sporadic. So what are the common causes of HCC in children? I think you can sum it up, Naresh, you can tell that.
I think essentially it's been told that it's HPV and HCV. With the vaccination, HPV hardly we see. And our personal experience in last 10 years is we never had a child with HPV or HCV having HCC. Most of them are metabolic. Some of them are biliary atresias with cirrhotic liver. Though they don't have jaundice, they have developed HCC.
So Dr. Joy, Dr. LVK will not have any place to talk anymore, no? They can't see also. If we don't see, they will also not see.
Be, I think once the liver
slowly everything will come, the old elder thing, so you will not have. So the main thing today, our discussion, so I want you to remember that 70% can be in a normal liver and only 30% they have underlying a cirrhosis due to metabolic liver disease, due to a metabolite or something like that. So today it is metabolic and so what are the metabolic liver disorders associated with HCC? I think Nirmala, you can identify all of them. There are names, but how many have you seen? I have seen only two. I have seen one PFIC2, I have seen one GSD with adenoma, tyrosinemia, and I have seen one GSD4. Have you seen any?
I have seen GSD with adenomas but not HCC because we treat only up to 12.
So BSS, see the older ones, we are the old people here, so you would have seen. You have seen so he's still young. Naresh, you have seen. Metabolic liver disease.
We have seen mainly metabolic with tyrosinemia and biliary atresias. Wilson, PFIC is type 2 we have seen.
Ramakrishna, young or old, let me see. Have you seen malignancy in a metabolic liver disease?
I don't think I have.
Rose, so you're all young, so you still have to wait to see that. It's rare, but then but it does occur. So GSD1 adenomas can become HCC, and then PFIC2, I think I've seen one even before the transplant. It was sad. Wilson, somehow we've not seen, though they report. I think all of us have seen so many Wilson, but we have not seen. Maybe our mutation is different, what we see. Tyrosinemia is probably the most common cause, and so I put it in red because it is so common, and it's the most common metabolic liver disease which will present with HCC. Then PFIC, of all the PFICs, PFIC2 because of the bile salt, and of the GSDs, GSD1 and 3, we are seeing that's the one we keep for exam. There will be adenoma going into HCC, but GSD4, I have seen one child, I never thought he would even go in for HCC. I thought everything would be all right. And then I think Jayanti remembered that, and she said, publish a GSD4 with HCC. So what I have to remember in metabolic liver disease with HCC, which is our topic, is you do not always have to go through the period of cirrhosis, and you have only a minority of the metabolic liver diseases get it. So there seems to be some modifiers, and that's a latency period. It's not that they get MLD and then they get HCC. There is some time, so you have to remember these 3 points. So this is in tyrosinemia, I was telling you, is the most important metabolic liver disease which causes HCC. And it is something very unusual because in tyrosinemia 1, you have high alpha-fetoprotein even when they do not have HCC, and we use it as a diagnostic marker, as a screening. So AFP, which is used as the diagnosis for HCC, can also be used initially to make the diagnosis of tyrosinemia. So it is a very paradox. So it's very difficult to diagnose it in these children, but this is one child of tyrosinemia. So tyrosinemia and HCC, we should all remember that the deficiency is due to this enzyme, fumarate acetoacetate hydrolase. At least remember FAH. And why do you get HCC is because just above that, I'll show you the diagram, wherever this has to work here, FAH should work here in the tyrosine metabolism. Because this is not, it is deficient, you get these two products. Just the products above that. In the tyrosine metabolism, this is the last step where FAH should work. FAH is not there. So these two products increase. These two products are mutagenic, and therefore you get HCC. And these two products can convert to succinylacetone, and you get that. So what is this thing between association with tyrosinemia and HCC? Just remember this. the incidence of HCC in tyrosinemia average 40% of tyrosinemia, and that's what you're worried about. 40% can go in for HCC. The prevalence increases with age, and hallmark of tyrosinemia is the high risk for HCC. So the clinical presentation, they can present either in the infant stage or later on. In infancy, when they come in the newborn period, very, very important to pick them up early, because I will tell you later why that is important, the treatment. You find that the persistently prolonged prothrombin time, that is one which never gets corrected. You get ascites earlier, and they usually present as acute liver failure. Later on, it will be just like, a chronic liver disease or as neonatal cholestasis. Older children, you will get chronic liver disease, and this is one condition because of the products. Like you have the other pathway where it behaves like a porphyria, like you can get even neurological symptoms and kidney involvement. So the diagnosis, though there are several things, here what we use for general is a prolonged prothrombin time, a grossly elevated alpha-fetoprotein, and a urinary succinylacetone. I think this combination, this triad is more than sufficient to make a diagnosis. Do you agree with that? Tyrosinemia is enough. We don't do the genetic mutations much, but if you do it, then it's confirmed. But these three are more than enough, though Dr. Kelly said it's not invariable, but somehow we rely on urine succinylacetone. Is your comment, Dr. Venugopal? I think Dr. Ramakrishna would have seen some children of tyrosinemia in CMC. They didn't refer, no?
No.
Older children maybe would have suspected.
Tyrosinemia, we always think about it.
Think
but
about
I don't
it.
think I've seen a child with tyrosinemia.
So I don't know whether in they would have seen, but maybe Chandan would have seen in ILBS, they all would have seen a case of tyrosinemia. And only when you do the alpha-fetoprotein as a screening test, even in neonatal cholestasis, can you pick it up. If you don't do that, it will be just like that. So if you pick up a high alpha-fetoprotein and you feel that there's no HCC, Dr. Naresh was saying in the newborn, you get very high values. But here you are getting 2 lakhs. So if you get that value, you have to send for urine succinylacetone. And if you don't send for urine succinylacetone, you don't make a diagnosis. Maybe we lost some of our tyrosinemia without a diagnosis. We don't know. So I think we should look for that, and then we do have, because now we are seeing, the more we look. So what the mind knows, the eye sees, and then you do it. So alpha-fetoprotein is now included in that. And the hepatic histology is non-specific. And this is just one child where a tyrosinemia child who had I think Dr. Naresh will remember, this was a tumor. This child did not have treatment. So I'll be talking about the treatment later, no treatment. And then the child goes in for a resection, and here you see the trabeculae and you see the tumor cells with hyperchromatic nuclei. And this is the staining. So this is the case 2. This child was born, the one we are going to talk about, just 2 more minutes we can take. Birth at Dhaka, November 13. And then child is taken to Delhi. The problem at that time was from birth, the mother has noticed as failure to thrive, there's pedal edema, facial puffiness. Someone has thought of a liver disease. They always found the prothrombin time is prolonged. Alpha-fetoprotein was very high. And so the urine succinylacetone was done, increased, diagnosed as tyrosinemia, and started on one medication called NTBC. This child was given this medicine 2015, 2016, and then, there are some problems. One, mother doesn't want, then the parents will say, relatives will say, why are you giving one medicine like this? Child looks well, all sorts of things will come. So their issues were cost of medication, problem of availability. Then someone said, risk of malignancy. So they also came to Chennai. So they came over. And so, Dr. Naresh, what do you think? Starting NTBC was a good choice of treatment at the age. And how does NTBC help?
Essentially, NTBC is a drug which is approved for treatment of tyrosinemia. But it has to be started as soon as possible after birth, at least less than 6 months. If you are more than 6 months, there is an increased risk for HCC. And also the cost of this medication is around 60 tablets cost around $5,000.
So you agree that it's a good drug given at 1 milligram per kilogram, and you get the rapid reduction of the toxic metabolites. See, NTBC acts here at the second path step. So if it acts here, then these 2 products which are the actual culprits for forming HCC are not formed. So NTBC is a drug, as I told you earlier, it is a drug, it's a long name, but NTBC is that, it's called nitisinone, not available easily in India, but can be imported, it is thing. But as he said, you have to start it early. And how early? That is the problem. So what is the ideal age to start NTBC, Dr. Venugopal? And how long should we continue NTBC?
Ideal age to start is before 1 month if you can.
Before 1 month. So how to make the diagnosis? That's the big problem. So, okay.
And it has to be continued for lifelong.
So this is very, very important. So if you start it in the first month, the relative risk, if you start it at 2.5, is 2.5 if you start it after the age of 1 month and before 6 months. So the relative risk increases to 6.3 if you start it between 6 and 12 months. The relative risk for HCC is 12.7 if you start it after 1 year. So everything should be done before the age of 1 month, which is so difficult. So difficult. So like someone was saying, antenatally itself, should we think about it? So suppose the previous SIB. So if you start it early, within 30 days of birth, as Dr. Venugopal was saying, there is a definite decrease in the incidence from 37% to 1%, and the need for transplant itself decreases. So this is one wonder drug which people feel should be given, and therefore tyrosinemia is included in the neonatal screening, and they say that you start it early and you will definitely get good results. You can prevent this liver transplantation. So how should we follow up a child on NTBC and how do we detect? I think you've already said that. We are going to finish. Yes, you follow it up, and these are some of the opponents of NTBC. What they feel is even if you give NTBC, some of the genetic expressions, the signal transduction, the cell, nothing changes. And so they are not too for NTBC. I don't know, NTBC, are you NTBC pro or anti?
No, NTBC changes your phenotype from type 1 tyrosinemia to type 3. Still, you have to manage the child with tyrosine-free diet. So it's not actually making a big change in your lifestyle. So personally, we think transplantation will make your life change from a difficult
What do
thing
you
to a
think,
normal
Dr.
child.
Venugopal? You're anti or pro NTBC?
Cost also has to be taken into account because
Cost.
yeah, if for a transplant, it's a one-time cost for NTBC.
So I think it's one time is most important. So if you give NTBC, you give lifelong, and they should also be on a tyrosine-free diet. So would you advise continue NTBC? You said no, check AFP, if decreasing, continue NTBC, do CTC and abide. Or would you say AFP, do a CT and prepare for transplant? I think it's your institute, so.
Yeah, at the end of the day, what the parents want, if they are affordable and thing, but most of them we go for a transplant.
But Naresh speaks to
because
them
once we
so
see-
well, so they talk like what you want also, no? So that's the way you should talk. You should talk the way that you want them to talk, and then they get the same answer. So it's like asking your students, what you want, you should be able to get it. So this, sir, you wanted this. Is it possible to diagnose antenatally? And I think, yes, we've got that. You can do it. And I think this is very, very important. So if you want to start it early, this is very, very important. If you have a SIB or there's a family history, then maybe you can do antenatal diagnosis. You can measure the amniotic fluid, and you can, mutation analysis has been done. And so early transplant, we've talked. And so early transplant in tyrosinemia, if they do not respond, a sustained rise in alpha-fetoprotein, or if they fail to respond, I think we have to do liver transplant. You agree to that? So even if you start it early, if you start it on time, if you start it within 1 month, but the current indications are probably unresponsive acute liver failure, you make a diagnosis. 1 week you give NTBC, no improvement, you're supposed to send them straight for transplant. Established HCC, or if you have a chronic liver disease with future risk. So here this child went through a living donor liver transplant. The mother was the donor, and the explant histopathology showed tyrosinemia with mixed nodular cirrhosis, multifocal high-grade dysplasia, no evidence of HCC. Do you think we did too early, we done the surgery, or was the correct time?
Here we are not trying to treat the cirrhosis, we are trying to treat the disease.
So I think it's the right
this
time.
should be a right time because it makes them, gives rickets and lot of other issues. So when we find the diagnosis, I think it's better to go ahead with the transplant
So I
rather than
think
waiting
this
for
child
something to happen.
transplanted, I think they're coming for regular follow-up. It's 3 years. Most important, no NTBC, no tyrosine diet, and both are happy, and the doctors are also happy. The child is doing very well, and I think you've also learned that tyrosinemia is the most important liver disease, metabolic liver disease, with HCC, you should start treatment, but if you start it early. And pediatric HCC, remember that it differs from adult HCC, and it can occur even in the absence of cirrhosis. We'd like to thank their team for sharing, and Dr. Joy also for getting me some data, and Dr. Naresh, Mukul, Jagdish, and Professor Ela. And thank you all, otherwise this team, and thank you Dr. Ramakrishna and Nirmala for pitching in, and three of you. And for Ravi, sorry, we kept you quiet. Thank you so much. Thank you.
Thank you. Thank you.
Thank you, Dr. Malti, for a wonderful session. We thank the chairpersons and the panelists for this session. So now we come to the last session. It's on HCC surveillance post-liver transplant. Dr. G. Loganathan and Dr. R. Ganesan. Okay. So this talk was supposed to be given by Dr. Anand Kakkar. Now it will be given by Dr. Ilango Sedu. So the topic will be HCC surveillance after liver transplant.
We invite Dr. Ilango to give the talk, the last topic of the day.
Thank you for the organizers for the opportunity. I'm standing in by for Dr. Kakkar. Whenever we come to the last lecture, I remember Randy Posh's last lecture. He's a computer science professor from the Mellon Institute at Pittsburgh. Randy was dying out of pancreatic cancer when he delivered the last lecture about the development of artificial intelligence and animation. Whenever we come to the end of a session, I always remember. And I'm happy to say that today I'm here to give the last lecture of the day. It's on surveillance after liver transplantation for HCC, the whys, whats, whens, and hows. The underlying premise for liver transplantation in HCC is a 70% survival at 5 years. This is equivalent to the survival when you do a liver transplantation in the absence of HCC. So this goal must be met at all times. The recurrence rate when you do a liver transplantation within Milan criteria is about 8 to 10%. And if you do a transplantation for a HCC beyond the Milan criteria, the recurrence can go up to 40%. One must remember that when the recurrence occurs, the median survival is roughly 9 to 10 months. And currently, we have no evidence-based guidelines for post-transplant surveillance for HCC recurrence. If you look at this slide, this tells you at 60 months, that's 5 years, your survival will be somewhere around 70%. But if you have a recurrent HCC, the survival drops very rapidly to around 25%, which is quite unacceptable because when you do liver transplantation, you lose a donor organ as well, even when you're doing a live donor transplantation. And if you look at the recurrence patterns in HCC, most of the recurrences happen in the first year after liver transplantation. Most of them happen within the first 2 years. And after that, the incidence comes down. And even at 5 years, patients continue to throw up new tumors. So recurrences can happen even at 5 years. And so that means you have to screen them for a longer time. So now, you have to identify a patient who has high risk of recurrent tumor after HCC in liver transplantation. So when you look at that, you have to decide prior to transplantation which tumor requires transplantation. Now we are attempting to predict the recurrence in these patients. The size and the number of lesions that you measure on CT scan using the Milan, UCSF, the up to 7 criteria, whatever criteria, they are surrogate markers for vascular invasion. They are static lesions. So these are static criteria to assess how the tumor will behave in the long run and how much of tumor will come back to kill the patient. So after running through a gamut of stuff, the selection was ultimately decided to be based on strict criteria based on the size and numbers, and they are the only criteria which have been found to have an impact. It also matters when you do the transplantation, how you do the transplantation to reduce the risk of recurrence. The explant is the key part of a liver transplant surgery. If your explant estimated blood loss exceeds 4 liters, those patients are at high risk of recurrence after the transplant. So HCC transplantation is quite easy. They are called the fellow cases in US where we are trained. The blood loss is extremely minimal when you do the explant in a HCC patient. Donor age has an impact. Donors more than 60 years of age have higher incidence of recurrence post-transplant. And they also found that fly-out organs, the organs which travel across the country, which does not happen in our place, so they are associated with longer ischemic times. So they are associated with more recurrence. So local organs are preferred. And the use of induction immunosuppression with thymoglobulin, which rarely we use, was also associated with higher recurrence. And higher CNI exposure after the first 3 months is also associated with the higher recurrence, more so with cyclosporin than with tacrolimus. But even then, tacrolimus higher levels are associated with higher levels of recurrence. And we also know that the mTOR conversion can happen at 10 days, 30 days, or 90 days, depending on the protocol which we use, is associated with much less recurrence. Now, the third way we can assess the risk of recurrence in HCC is to look at the explant pathology. There are 3 parameters which we look for. If you have done any pre-transplant therapies, the presence of viable tumor will indicate that the risk of recurrence exists in these patients. But the most important criteria is the poorly differentiated tumor. The response to all therapies will be less. They have a very high risk of recurrence. And microvascular invasion. Like I said before, size and the number of lesions are actually surrogate markers for microvascular invasion. Now, do we have anything on the liver disease which caused the cirrhosis in the first place for the recurrence of HCC? Now, what is surprising is that NASH cirrhosis in men, when you do the transplantation for the associated HCC, have a very low risk compared to viral diseases. But this phenomenon is not seen in women. And alcohol falls somewhere in between. Like I said, if you look at the donors, elderly donors donor livers do not do well in HCC recurrence. The easiest way to predict is the retreat scoring, but one must remember that the retreat scoring has been validated only for tumors within the Milan criteria. It does not apply otherwise. And if you see, some of them are things which we would never do. AFP is more than 1,000 is something which we don't transplant. We usually tell them it's a bad biology. And microvascular invasion, again, you pick up only in the explant. And the sum of the tumor and the number of viable nodules on the explant will give you the retreat score, and the screening can be adjusted to that. Most of the screening program is based on imaging and AFP at 6 months for 2 years or 3 years or indefinitely. Now, what do we do in our program? In our program, when we do transplants for HCC, the index CT scan evaluation is done at 3 months, sometimes at 6 months. It is a CT abdomen, triphasic, and sometimes when they have renal dysfunction, we do MRI abdomen. We always do a chest CT along with that, along with AFP. For frequency, when we picked up our protocols, we looked at explants with lymphovascular invasion based on the Miami experience to, if they have lymphovascular invasion, the first CT scan evaluation should be done at 3 months, and then 3 months thereafter, at least for 2 years. But if they don't have lymphovascular or microvascular invasion, we can extend that duration to 6 months, especially with no other high-risk factors like poor differentiation. And this 6 months imaging protocol always leads to less radiation exposure because we used to doing CT scans for these patients. The pickup rates were similar. Now, how long will you follow up? The only recommended time duration for follow-up of post-transplant surveillance is 4 years. It's quite an odd number. It's neither the 2-year or 1-year surveillance or 5 years for the tumor recurrence. But one should remember that the early recurrence, less than 1 year, indicates that the choice of transplant was made poor. We could not identify the high-risk patient who is at risk of recurrence, or we missed micrometastatic disease or microvascular invasions. Most of the recurrence, as I said, happens within 2 years, but the recurrence rates are rare, said to be rare after 4 years, but it never changes. All patients post-transplant for HCC, I believe, are supposed to remain on continuous surveillance for the end of their life. Even post 5 years, the recurrence rate is around 5%. Now, what will you do when the patient recurs? Most of the recurrences are extrahepatic. It's very rare to have an isolated intrahepatic recurrence. And if the tumor recurs within the first year, it's an extremely poor prognostic factor, and they usually die from the disease. An AFP level of more than 100 at the time of recurrence also indicates a very poor prognosis. And if you're unable to apply any therapy, obviously the prognosis is going to be poor. And survival is very dismal after recurrence. I don't think so anyone has a proper solution. We have found a few patients with localized recurrences for which TACE or RFA has been done, and sometimes robotic or laparoscopic resection, sometimes open resection have been done for these patients, but these are difficult situations. Now, to conclude, the recurrence of HCC post-transplant is a real issue. This is the way why we formed all the criteria in the first place. Definitely impacts post-transplant survival. Our ultimate goal in a liver transplant should be at least an 85% 1-year survival and a 70% 5-year survival rate. A recurrence will definitely bring down these numbers, so it's a very important factor. I have discussed the various pre- and post-transplant factors along the intraoperative factors. We don't have any hard evidence for any surveillance. Individual programs decide. I presented to you our protocols. A retreat score can help you stratify high-risk patients, and local recurrences within the liver can be treated. All extrahepatic lesions only need palliative supportive care. Thank you.
Thank you very much, Doctor, for coming and sorting out this last lecture. Dr. Barmas?
So, Dr. Ilangon, I have got a few questions to ask you. So, you have mentioned about the retreat score. Is there any score by name, moral score, that is pre-moral, post-moral, combo moral?
Combo moral is being evaluated. Unfortunately, we have never used these scores in our own practice, so we have no personal experience on that. But the combo moral score is supposed to predict this in a much better score than the retreat one.
So what of the surveillance? You have mentioned about the CT chest and CT abdomen. So what is the necessity to do CT chest in the surveillance study?
So the recurrence can happen, is usually extrahepatic. So the lung recurrence is quite common. So we look for that.
The first recurrence occurs in the lung or in the liver?
That's unpredictable. I don't think so there is a pattern in that. But if you look at HCC metastatic disease, usually we do this CT scan in the lung as well as in the bone scan. In post-transplant, we have an added layer of immunosuppression, so we find them in the skin and other areas as well. But I think the standard protocol recommendation is to add CT chest to the surveillance.
So any more questions from the audience?
I think we had a wonderful
no more questions. Thank you, Dr. Ilangon, for your excellent talk about surveillance in the post-transplant.
Thank you very much, Dr. Ilangon. I think we had a wonderful one-day session giving an overview of, not an overview, an extensive over interpretation of hepatocellular carcinoma. And I think we should thank the INASL for giving us an opportunity to conduct this midterm meeting. Dr. Joy, your concluding remarks, and we conclude with that.
It's the first time we are conducting here the midterm INASL combined with the Tamil Nadu ISG. So our thanks to the patrons, Professor KRP sir, Dr. Balasubramanian sir, and I have to thank the Tamil Nadu ISG, the secretary, Dr. Ubaldas, and the treasurer, Dr. Prem, and all the faculties who has come here, the chairperson, speakers, and particularly those who has traveled from other state and outside the city. So my sincere thanks to all of them and all the delegates. And special thanks to Professor Jayanti ma'am for timely conducting program, the Master of Ceremony as usual. And I have to thank to the stage 3 who helped for the stage alignment, and as well as the audio visual, Mr. Sriram, and our hotel managements who helped for the accommodation and all the things. and all the pharma industries who have supported our event today. So once again, thanks. Thank you.
There
Good
were,
evening.
there
Thank
were a few problems because of the speakers not being available. So for that, on behalf of the team in INASL, we apologize for that.
Another, my sincere thanks to my co-joint secretary, Dr. Murugan. So yesterday he took the program in Apollo, the PG clinic. It went on very well. Thank you. Thank you so much for